your fellows are not that. It's typical that they're obviously still all meeting virtually, right? People are not getting together for educational seminars.
No, we are.
Yeah.
I think I'll begin.
Please do.
By welcoming Ruth Faden to participate in our lecture series on ethics in the COVID-19 pandemic. It is such a delight to have Ruth with us for this meeting. Let me just say a few words about Ruth Faden. She's the founder of the Johns Hopkins Berman Institute of Bioethics, widely regarded as one of the great bioethics programs in the world, and not just in the US, and served as the director, as the founder and then the director of the Berman Institute from 1995 until 2016. Ruth is also the Philip Franklin Wagley Professor of Biomedical Ethics. I remember Professor Wagley as a great doctor.
Yeah.
Her research focuses on structural injustice and public policy. Dr. Faden is the author and editor of many books and many articles on biomedical ethics and health policy. Let me just give you a couple of the books that she's been author of. Social Justice, The Moral Foundations of Public Health and Health Policy with Madison Powers. A History and Theory of Informed Consent with Tom Beecham. AIDS, Women, and the Next Generation, which she was co-editor of, and HIV, AIDS, and Childbearing, Public Policy and Private Lives, which she edited with Nancy Cass. Ruth Faden is a member of the Institute of Medicine, a fellow of the Hastings Center and the American Psychological Association. She served on numerous national advisory committees, including President Clinton's Advisory Committee on Human Radiation Experimentation, which Ruth was the chair of that committee. In 2011, Dr. Faden was the recipient of the Lifetime Achievement Awards from the American Society for Bioethics and Humanities, the ASBH, and Public Responsibility in Medicine and Research. Currently, Ruth Faden is working at the intersection of structural justice and the COVID-19 response, primarily in vaccine allocation and prioritization, and also in K through 12 education. The title of Ruth's talk today is Allocating Vaccine in a Structurally Unjust World. Ruth, I can't tell you how happy we all are to have you join us.
Mark, you are ever gracious. So if we could just get it in present mode, that would be great. Thank you. Mark, you are always gracious. And I want to thank you and all of your colleagues at the MacLean Center, which is a center I've admired for a long time, for everything that you stand for and all the work and people that you've trained. So this is a great opportunity to talk with you today. You asked me to address ethical issues connected to the pandemic. There are obviously no shortage of those that I could have decided to speak with you about. But as some of you know, and Mark's already referenced, for many years now, I've been heavily engaged in a research program with my dear colleague, Madison Powers, on justice theory, and particularly structural injustice. And since about, trying to figure out when this was, but certainly since early days in the pandemic and officially since June, I've been heavily engaged in work on the pandemic vaccine, most primarily, and most importantly, I guess, I sit on the WHO SAGE working group on COVID-19 vaccines and vaccination. That's the group that provides advice to the group that then advises the Director General of the WHO and is then responsible for the policy positions that the WHO has taken and will continue to take on vaccines during the course of the pandemic. I've also worked on the vaccine issue, of course, nationally as well. And whenever possible, what I've tried to do is connect the dots between my interest in my work and my commitments to structural justice and my work on vaccines. And Mark mentioned I also work on K through 12 education policy, and happy to talk about that during the Q&A if people would like. So in the talk today, I'm going to again try to kind of draw some connections between structural justice theory and vaccine allocation. Next, please. The talk's in two parts. I'm going to present in short compass an overview to structural injustice, and specifically to the account of structural justice that Madison and I defend. And then in the second part and longer part of the talk, I'm going to be looking at the pandemic and the pandemic vaccine allocation issues specifically. I'm going to address some of my remarks to global structural injustice and pandemic vaccine access at the global level. And then I'll close with some remarks about the national level. And in that, I will try to make some connections to theory from time to time. Next, please. So I have to do this. I don't know if Madison knows that his picture shows up on the slide, but it does. My dear colleague, Madison Powers. And this is the copy of our most recent book, Structural Injustice, Power Advantage and Human Rights, that came out in 2019. Next slide, please. So let's start with what makes structural justice structural. Structural theories of justice share one overarching assumption. It is the assumption that social arrangements, including certain institutions and social practices, have highly consequential, differential, and sometimes unjust effects on individuals because they are members of identifiable social groups. It is because they belong to certain groups that are identified in the social structure for differential treatment and valuation. Our theory shares and builds on this assumption. It is designed, our theory, for the world as we find it, and addresses basic or foundational injustices that arise within countries, and indeed in all countries, but also that arise globally between countries. Next slide, please. The theory begins with an account of well-being, the core elements of which are health, personal security, knowledge and understanding, personal attachments, equal respect, and self-determination. Each of these elements of well-being are selected because of two criteria. First, they are the kinds of things we claim and defend that everyone would want, regardless of what else they would want in their lives that is particular to their values, their time and place, and history. So we defend the position that each of these are things, states, if you like, that everyone would want to have, regardless of who they are. But also, because this is a theory of structural justice, the elements on our list must be elements that cannot be secured or reliably secured by individuals on their own, but instead depend on the just structure of the society in which people live. Next slide, please. Now, this 6-element conception of well-being provides the foundation for human rights, explains the depth of unfairness of systematic patterns of disadvantage, and locates the kinds of fundamental unfairness that result when some groups have unfair control over the well-being of others. So what I want to emphasize here is that each of these represent distinct forms of injustice. When institutional protections fail to safeguard predictable and severe, but remediable threats to well-being, that's one kind of structural injustice. Yet another kind occurs when members of some socially situated groups are systematically disadvantaged relative to other groups in their prospects for realizing well-being. So that's a distinct, separate kind of structural injustice. And finally, a third form of structural injustice occurs when members of some groups have unfair power over the lives of members of other groups. Next slide, please. I want to take just a minute to say a bit more about disadvantage and unfair power relations. So there are lots of different sports metaphors that could be used to illustrate what we mean by systematic disadvantage. It's basically the notion that comes to mind when we talk about society or the global economy, for example, being fixed or the rules having been rigged. It's the state of affairs where some people, because of the groups they belong to, are regularly confronted with hurdles and barriers that occupants of more privileged or more socially favored positions in groups never have to navigate. So you begin at the starting line behind merely because of your membership in socially situated disadvantaged groups. When we write about power, as we are talking about unfair power relations, and we take great pains to distinguish between three different ways in which unfair power relations can manifest themselves. They're, again, distinct in terms of their impact on people and their claim to being structurally unjust, but they're all a function of unfair power relations. So we talk about subordination, or if you like, domination, where, again, some groups have unfair control over the lives of other groups, people in other groups. Social exclusion, which is the context in which some people, because they are members of socially situated groups that are disfavored, are excluded or permitted only marginal participation in some valuable activity or social interaction. And exploitation, which is the taking advantage of the advantaged, powerful position that some groups have for the benefit of that group. So it's taking advantage of the fact that some groups are disadvantaged in order to benefit, to continue to benefit, and then to perpetuate the advantage of more powerful groups. Next slide, please. Though morally distinct in our theory, structurally unfair patterns of power and systematic disadvantage are routinely intertwined with each other and with human rights violations. So all of these three forms of structural injustice are cause and effect of one another. Human rights violations and serious deprivations of well-being generally usher in structural unfairness in patterns of advantage and relations of power. And both sorts of structural unfairness, systematic disadvantage, and unfair power relations themselves incubate human rights violations and serious deprivations in the core elements of well-being. This interactive process, this cause and effect dynamic between unfairness and disadvantage and deprivation, so between unfair patterns of advantage and unfair relations of power and deprivation and human rights violations, the interrelationship between these three processes is the central message of our theory of structural injustice. So that's sort of a quick thumbnail sketch of the approach that we take to structural disadvantage, Madison and I take, that informs my thinking as you'll hear it expressed now as I turn to the pandemic and pandemic vaccines. So next slide, please. I think at this point in the pandemic, and certainly with this group, I don't need to rehearse the just extraordinary, devastatingly awful impact that this pandemic has had. These images here are, and these short sort of descriptive statements are just meant to kind of summarize in wholly inadequately what has happened as a consequence of this pandemic. I just really want to make 2 points here. The first is that this pandemic has resulted in severe deprivations in all the core elements of well-being for countless people around the world. And the second point I want to make is in the world's poorest countries and among the world's most disadvantaged and powerless people, these deprivations have been the most severe. Next slide, please. So into this global nightmare, basically, enter vaccines. We have about 7.8 billion people in the world at the moment. We know that some, if not perhaps most, of the vaccines that will become available, that are already available, and even that will become available will require 2 doses. But even if we're able to use 1-dose vaccines in large numbers, we're still talking about a massive, like billions and billions of vaccine doses if we're going to even begin to approximate providing vaccine to everyone who could benefit from it. So we have this acute near-term and I would say longer-term vaccine shortage. And we have, on the one hand, the aspiration that vaccines will be justly allocated globally. And on the other hand, we have the horrible fear that what will in fact result is unconstrained, completely unconstrained vaccine nationalism. Next slide, please. Now, what would it mean to distribute vaccine globally in a just allocation scheme? Well, in an ideally structurally just world, we would have some set of morally defensible criteria that would be used to allocate vaccine to the peoples of the world, regardless of where they lived. This is a very simple representation. It is by no means the most defensible, ethically defensible way to allocate vaccine globally. It simply says, if we were to allocate vaccine globally, proportionate to population size to all of the countries of the world, how many deaths would be averted versus a scenario in which vaccine were allocated initially and primarily to high-income countries. This is a model, it's projection. It was completed at the end of 2020, so it isn't based on particular numbers or a particular accurate sort of real-world scenario, but it came actually very close. And you see that here this model predicts this dramatic difference in terms of the numbers of lives that would be saved if we were able to allocate vaccine globally along a very simple equality interpretation of what just distribution would look like. I'm not going to spend any time at all on this question of what a globally just allocation scheme would look like, because it's not going to happen. Next slide, please. We don't live in a structurally just world, far from it. Rather, we live in a world of profound differentials in wealth, in geopolitical and economic power between high-income and middle-income and low-income countries. A world in which LMICs engage in negotiations with other states and with non-state global institutions and corporations from a seriously disadvantaging bargaining position. To put the words of our theory to work here, low and middle income countries, especially low income countries, are functionally powerless in many cases to avoid arrangements in which they are dominated, to avoid arrangements globally in which they are excluded from powerful seats at the table, and to avoid scenarios globally in which they and their people are not exploited. So in the world in which we find it, this profoundly, globally, structurally unjust world, this is the result. This is a quote from the Director General of the WHO. Some of you may have seen it. It's about 3 weeks old. I'll read it really quickly. Dr. Tedros's words: "The world is on the brink of a catastrophic moral failure. More than 39 million doses of vaccine have been administered in at least 49 higher income countries. Just 25 doses have been given in one lowest income country. Not 25 million, not 25,000, just 25." So that was 3 weeks ago. Next slide, please. This heat map is up to date as of February 8th. It's from One World in Data. Obviously, the darker the color, the more vaccine administered per 100 people in the population. Where you see no color, there has been no vaccine rollout as of yet. Also, as of Monday, there is still only one low-income country, and that is the same low-income country that Dr. Tedros was referencing to the 25 doses, and that is the country of Guinea. So one low-income country, and Guinea is now distributed more than 25 doses, but it's only one low-income country so far, and that's in contrast to 63% of the high-income countries of the world, which have already started vaccination programs, and about 20% of middle income and both upper and lower middle income countries. Next slide, please. So some of you may be familiar with the COVAX facility. This was the institution that was established, a very novel institution, to try and avert an outcome in which there would be profound global inequities in access to COVID-19 vaccines. Its goal is, in fact, a global mechanism for pooled procurement that will result in an equitable distribution of vaccine around the world. That is the goal. I won't go into the details about the way the COVAX facility is structured. It is administered by the World Health Organization together with Gavi, which is an NGO that has for a very long time had the mission to facilitate the securing and the implementation of vaccine programs, especially childhood vaccine programs in the world's poorest countries and also in middle-income countries as well, and something called CEPI, another acronym I can decode in Q&A if you like, which was set up after the Ebola disaster to see if the world could not more quickly get to vaccines for emerging and re-emerging pathogens and do so in a way that would facilitate global access. So bottom line now, 98 high-income countries and 92 low and middle-income countries are members of the COVAX facility. The lowest income countries are subsidized. There are some self-paying countries that are middle-income countries, and all the high-income countries are self-paying. So far, I think it's a bit more than this, but so far COVAX has raised $2.4 billion, but it needs at least another $6 to $7 billion by the end of 2021 if it is to come close to the goal that COVAX set for itself, which was to provide vaccine to all of its member countries up to the coverage of 20% of each country's population. That goal will not be met in 2021. Next slide, please. Short of something very dramatic happening. And here's one of the reasons why. It is not only the fact that wealthy countries have stepped up ahead and begun vaccinating their populations, and it is not simply the fact that the wealthy countries of the world have not been as forthcoming with funding as those countries should be, but it is also because high-income countries have been effectively cornering the market in terms of procuring actual vaccine and contracts that will obligate future production to their countries. So I don't know how well you can see the details in this slide, but just to point out, Canada, for example, has secured vaccine sufficient to cover 6 times its population size. The US, more or less 4 times, and so on. So from a global structural injustice standpoint, how should we think about this current state of affairs? Does this visual then represent unconstrained, ethically unjustified vaccine nationalism? Are some countries behaving better than others? I will just point you to, for example, Japan and New Zealand, who have secured vaccine for just a little over 100% of their population, in contrast to countries that have 3, 4, 6 times the amount of vaccine that their country needed to cover their country population. So how do we ask and answer this question about what constitutes justifiable partiality or justifiable nationalism in the space of COVID-19 vaccines, and what is unjustifiable from the standpoint of structural global justice? Now, in our book, we take the position that in the world as it is, the world as we find it, the current global order, it is only nation states that have the institutional capacity and political legitimacy to secure the core elements of well-being and address the structural roots of human rights deficits. And thus it is their moral responsibility to do so. That is, countries have a moral responsibility to promote and protect the human rights of people living within their territorial boundaries, and also to continuously rearrange the levers of structural institutions so as to reduce structural unfairness, either in the form of patterns of disadvantage or in the form of unfair power relations. The implications of this position, that right now in the global order as we know it, states have this special position with respect to human rights and unfairness for the pandemic, is that countries indeed do have a moral obligation to secure vaccine for those living within their boundaries. The pandemic is, after all, posing a severe threat to every core element of well-being. And I don't have the opportunity to sort of spell this all out, but on our account, access to vaccine would fall under a human right. However, that there is this obligation on the part of states is far from the end of the global justice and human rights story, both in general and when it comes to pandemic vaccines. In our book, we also take up the moral responsibility of nation states to address the impediments to human rights fulfillment that flow from differentials of interstate and global institutional power, and that result in large gaps in human rights protections for millions upon millions of people around the world. So we are thinking here not only about the unfair system of relations between states steeped in dramatically differential global power, economic power, and advantage, but also the fact that many people live in either failed states or corrupt states or outside of state regimes. And with that in mind, we develop and defend 2 principles. I won't only go through one of them here, because this one, the second one I'm going to speak about, does establish substantive moral restraints on wealthy countries in the global pursuit of their own interests. So could I have the next slide, please? We call this the principle of interstate reciprocity. And it prohibits a country from pressing for advantage for its own citizens and residents when pursuing national advantage on the global stage would undermine the human rights of citizens of other nations, or put another way, undermine the capacity of other nations to fulfill its obligations to their citizens, and where foregoing the pursuit of advantage does not thereby pose a substantial risk to the basic human rights of the country's own citizens. So a few things to note about this principle. It is not a cosmopolitan or does not involve a cosmopolitan or impartial concern for the overall welfare of all human beings. So this is not a cosmopolitan principle, nor do we have what's called a cosmopolitan theory. On the contrary, this principle, the interstate reciprocity principle, presupposes that it is acceptable for countries to behave in some self-interested international behavior and bargaining. It takes for granted the widespread assumption that all nations, whether rich or poor, have good reasons to promote the interests of their own citizens and residents. And moreover, we argue that states have a special primary duty, moral duty, to ensure the satisfaction of the human rights of those within their boundaries. However, right, the pursuit of advantage on behalf of your residents, your citizens, those living within your territorial boundaries, is not unconstrained, right? Pursuit is constrained when in so doing, one nation state prohibits other countries or significantly compromises the ability of other countries to fulfill their obligations of human rights protection to their own citizens. Next slide, please. Some echoes of the principle of interstate reciprocity in our theory can be found in the WHO's values framework for the allocation prioritization of COVID-19 vaccines. That framework, which I'm happy to discuss in detail, does include a principle of global equity in two parts. It says that countries that have a lot of money should refrain from undermining vaccine access to low and middle income countries. And it says that countries should participate and support approaches to ensure access to COVID-19 for resource-constrained populations, including through COVAX, but through other mechanisms as well. Next slide, please. So, what would the principle of interstate reciprocity or the WHO principle of global equity look like concretely if it were instantiated today and made to fit the current context of global access to COVID-19 vaccines? I don't have a concrete substantive answer to this question, a crisp sort of line that countries should not cross. But it does seem, at minimum, plausible that either the principle of interstate reciprocity or the WHO principle of global equity would likely preclude Canada or the US from locking up the global vaccine supply to the tune of 6 times or 4 times what it needs to immunize its entire population, even allowing, and I'm sure we can get into this in discussion, for hedging bets with respect to which vaccine candidates are in fact going to cross the finish line. To paraphrase a New York Times headline, rich countries have cleared the shelves of vaccine before the other countries even have had a chance to go shopping. If there was ever an example of the global involvement and exploitation by wealthy nations, right, of unfair exercise of power or unfair use of patterns of advantage in a global marketplace, when such consequential issues are at stake with respect to the core elements of well-being, I don't know of one. Now, this is a kind of rhetorical way of saying, I don't think it's hard to make up the case that at least some countries have already overstepped even a generous interpretation of what is acceptable from the standpoint of national prioritization, national priority, national partiality. But as a practical matter, it's not likely that global justice arguments alone, no matter how compelling, and even if we make them super concrete, say, and link them up to something having to do with, for example, the rate of transmission and the role the vaccine plays in that regard, I just don't see global justice arguments alone as sufficient to move wealthy countries to behave differently than they have been behaving. Self-interested arguments will more than likely be the ones that shift the behavior on the part of wealthy countries. And there are 3, and I'm sure everyone here is familiar with them. There's the standard but absolutely compelling national interest from the standpoint of health. All countries have a self-interest in containing the pandemic globally in order to protect the health of their own citizens. This is the standard. If there is an outbreak anywhere, there's a chance of an outbreak everywhere. And additionally, we now see the powerful role that inadequate access to vaccines could play in terms of incubating very, very troubling variants of SARS-CoV-2 and ultimately sort of upsetting or undermining or compromising the impact of the vaccine effort overall. There are also compelling economic arguments. I won't rehearse the data from the modeling that has been done, but suffice it to say that failure to contain the pandemic in low and middle income countries is an absolute prescription for global economic disaster of the sort that will profoundly affect the economic recoveries and economic well-being of wealthy countries. And finally, there are a lot of very significant geopolitical interests at stake. We can talk in discussion, if you like, about the role that the Chinese and Russian vaccines are playing in terms of geopolitics and soft diplomacy. And so wealthy countries of the world have an interest in becoming significant global players here in terms of relations with low income and middle income countries going forward. My own view is the best way out of this mess is through some interdisciplinary and intergovernmental and cross-national work that tries, among other things, to operationalize and model tipping points with respect to each of these three issues and as they relate to different ways in which wealthy countries can work towards meeting their obligations globally for an equitable vaccine access aspiration. And that includes not only diverting vaccine, but in some cases, but also vaccine access, understood in terms of related supplies, syringes, and so on, helping to build production capacity in countries in the global south, and straight out dollar support in negotiations with manufacturers, developers, and in working on the intellectual property issues. So a lot of work needs to be done like yesterday to try to put some arms around these tipping point parameters. And in addition, some coming together of the high income countries of the world, I don't know, it's kind of like a mutual pact, a verifiable commitment of actionable obligations that each country will undertake, a kind of Paris Accord in the near term for the COVID-19 pandemic, which will then, at least rhetorically, and hopefully with more than rhetoric, bind countries to specific commitments to redirect funds, vaccines, and vaccine supplies to low and middle income countries. So that's where I am right now with respect to structural injustice and the global vaccine access challenges. Let me turn now to the US. Next slide, please. Again, with this group, I have no need to rehearse how this pandemic in the US has affected socially situated groups differently. We have the narrative that we're all in this together, but that narrative fractures when we think about the reality that different social groups in our society are experiencing very different pandemics. True to form, this disaster, this pandemic, like all disasters, is widening, exacerbating pre-existing unjust disparities that were linked and are the the result of deep-seated structural injustices that have been in place for for hundreds of years and are in place today. So what I want to talk with you about for my remaining moments is how to think about structural injustice in the context of pandemic vaccine allocation in the US. But I want to emphasize one thing as we segue from the global situation to the national situation, and specifically the US national situation. We are not, right, in a lifeboat or Hunger Games scenario here. In stark contrast to many countries in the world, and in stark contrast to what many peoples of the world are facing, we are not up against a hard, fixed shortage. We are in the midst of a supply constraint, which is a very different scenario. We're not looking at an absolute shortage. And it's very important to emphasize that as we think through the ethics of how we should proceed. Unless something catastrophic happens, and catastrophic stuff has happened in this pandemic, so it's not impossible, but barring some big catastrophe with respect to vaccine production or the capacity of our vaccine pipeline to address variants in an efficient enough fashion, there should be enough effective vaccine for everybody in the US who wants it, and hopefully for everyone in the US who should take it. It's only a matter of time. Is it by the end of the summer? Is it by the end of the calendar year? Those are the open questions, but we are not looking at an absolute shortage. People who want to get vaccine should be able to get vaccine in the United States. So with that as important backdrop, can I have the next slide, please? In thinking about how to allocate in the context of supply constraint, so we are in a rationing context at the moment, we've seen any number of groups develop ethics frameworks or identify ethics values or ethics principles by which allocation decisions should be guided. In the US, the National Academies came out with a framework, a wonderful report at the end of the summer. The Advisory Committee of Immunization Practices, which is the committee that advises the CDC, came up with its own framework. Any number of independent groups have come up with frameworks. Some US states have their own ethics frameworks. The WHO has its own ethics framework. Many other countries have their ethics frameworks. What I'm doing here is kind of in short compass, taking most of the substantive principles, not all of them, that appear in these different documents, these different frameworks, and suggesting to you that most of the considerations fall under two big buckets. One, a set of moral considerations. I'm not going to now spend a lot of time worrying about what's a principle, what's a value, what's a commitment, what's a consideration, but a set of moral commitments that fall under a general heading of promoting and protecting human well-being, if you like, bringing about good stuff in the world and keeping bad stuff from happening. You see here 4 specific ways in which this general commitment to protect and promote human well-being has been further explicated in some of these documents. And then the other big bucket, I'm just calling equity and fairness. You could call it justice. You could call it any combination, but equity and fairness language is generally what you see in these documents. Again, I provided some examples of how the set of moral considerations that would fall under this big heading have been explicated in these documents. I want to just bring 2 things to your attention right now. The first is that what I called priority for systematically disadvantaged and disproportionately burdened groups, that value appears in so many of these guidance documents and is where the structural injustice issues are handled, usually using language of systematic disadvantage or disproportionate burden, or and the conversation nationally around equity usually refers to those considerations. Also, I've pulled out for your attention children, which in some but not all documents are themselves pulled out as a special group of particular moral concern, and I will refer to that a little bit more later. Now, next slide, please. These 3 specifications of the sort of moral commitment to address or prioritize the needs of systematically disadvantaged or disproportionately burdened groups are mine, right? There are 3 rules of thumb that I developed many, many years ago from the work that we first did on social justice and the moral foundations of public health and health policy as 3 simple rules of thumb for how we should think about allocation schemes from the standpoint of systematic structural injustice. First, we should avoid allocation schemes. These are pretty obvious that worsen outcomes and prospects for systematically disadvantaged, substantially burdened groups, disproportionately burdened groups, we should allocate where possible to improve outcomes and prospects for systematically disadvantaged and disproportionately burdened groups so as to narrow unjust inequalities by lifting from the bottom and not leveling from the top. And finally, we should construct guardrails against exercise of unfair advantage, against unfair power relations, corruption, and cronyism. So these are my 3 rules of thumb that I employ when I'm in a practical context and I'm thinking about allocation and I'm concerned about structural injustice. Next slide, please. But even with a specification of the sort that I've just provided of some of these moral commitments, you cannot read off from an ethics framework, even from a specified ethics framework, what exactly should happen in the real world. This is for all of us who work in the kind of practical ethics space, the moral theorizing, the identified ethics values and commitments need to be interpreted. They need to be interrogated in the context of the particulars of the decision problem, the particulars of the policy problem, the features of the landscape that give texture and color to how we should be thinking about the values, the commitments, the theorizing that we've agreed upon is relevant. So here I'm going to bring to your attention sort of 2 sets of additional considerations that need to be taken into account in addition to or simultaneous with the ethical values that are identified. And I'm putting them here also into 2 buckets, what I'm calling the pandemic context particulars and the public health and public policy and public values context. So first, under the pandemic context, whatever your values framework is, however it's articulated or formulated, you need to understand its implications in the context of the epidemiology of the pandemic at the time vaccines become available. Is it widespread community transmission across the whole country? Is it a context in which there is widespread transmission in some places, but only localized outbreaks in others? Has the pandemic been largely contained and the primary objective is to keep it that way? Where is the country with respect to the epidemiology of the pandemic at the time vaccine becomes available? Also, what if we learned that is different from the time when we first set up our values framework about how the pandemic is unfolding in terms of burden of disease and differential impact? Another set of considerations about vaccine supply. I've already mentioned in the US, we face a different scenario than in countries where they are not expecting very much vaccine, but beyond an initial tranche for another 6, 10, 20 months, who knows? What's the current supply? What's expected? What's the timing? What's the reliability of the supply? All of this matters. Of course, also relevant are the vaccine product's specific characteristics. We can have a conversation about 2-dose versus 1-dose, interval between the doses, whether the vaccine provides any documented or theoretical protection against onward transmission or only against severe disease and death. What about asymptomatic infection? What about the variants and so on? And finally, what's the current situation of the country at the time vaccine becomes available with respect to the level of societal and economic disruption that's going on and how vulnerable or resilient essential services, essential sectors of the economy are at the time that the vaccine becomes available or the first supplies, second supplies become available. Next slide, please. I'll try to do this in quicker compass. But again, with respect to the particulars having to do with the public policy, public attitudes, and public health context, what's the state of the immunization delivery system, the infrastructure, how well can the system handle what kinds of prioritization schemes? What about the infrastructure with respect to health communications and health promotion? And also, very, very foundationally important, what's the state of public attitudes, trust, vaccine acceptance, vaccine hesitancy? How is that distributed among the population? What are we doing about it? And so on. Next slide, please. Now, in the US, and indeed pretty much globally, there was something like a consensus about which groups should be the very first groups to be prioritized for vaccine when vaccine first became available. Those two groups, as everyone here knows, high-risk health workers, sometimes called frontline health workers, and residents of long-term care facilities, as well as the workers in those facilities who would also have been covered under high-risk or frontline health workers. So there was widespread consensus that these two were the first groups that should receive vaccine. As I said, that is true globally as well as nationally. I'm not going to rehearse the moral arguments that justify that prioritization. I'm just going to take it that everybody here understands the reasoning that was used to put those two groups first. Where we are now in terms of national prioritization for vaccine is that we're at the next step, and there are flashpoints, significant disagreements among both people who are working at the public policy level and who are working in ethics and modeling in infectious disease and so on, the sort of technical expert group, if you like, and among the public and among policymakers about some combination of these four groups: teachers and school staff, essential workers other than teachers and school staff, and I segregate them for a reason, older people, and people with relevant comorbidities, either who are younger or who are just, doesn't matter how old you are, you have a relevant comorbidity. I'm going to just take a minute on teachers, because I think the teacher controversy, and of course, I'm not, but many of you are in Chicago, where the flashpoint around vaccination in teachers has been particularly acute. It's a fascinating and, if it weren't so consequential, just a stunning sort of case study of trying to think through the relationship between what it means to have evidence-based or science-based public policies and policies that are based in or reflecting some combination of human psychology, politics, and raw power. So the one thing that there seems to be agreement about is that children are suffering disproportionately in this pandemic. I pulled them out earlier. I can give you kind of the theory reasons why the well-being of children matters disproportionately, both from the standpoint of a kind of a general account of welfare and also from the standpoint of justice. But we know that things that set back interests of children in childhood can have lifelong negative impacts. We know kids are suffering significantly, and we know that children who were disadvantaged before the pandemic are even more disadvantaged by the disruption of their education now, and it's disrupting school attendance, and the availability of participation in schooling is not simply a matter of disruption in your sort of academic skill accrual. It's much, much more that has been set back. So the question is, what role should vaccines play or need to play in saying that schools are safe enough for everyone to return to education in a physical building? And this is what I mean about, I'm happy to talk about this in Q&A. It's an interesting mix, because the evidence for the critical nature of vaccines for teachers as a matter of, quote, making schools safe just isn't there, right? But the human psychology and the politics and the power is there, right? So, and the recognition that teachers are a very important group of people that we all owe debts of gratitude, reciprocity, and so on for. I want to spend a couple minutes on essential workers, right? Because essential workers have been identified as the group that should be prioritized for a bunch of what I'm going to now call equity reasons. Remember, I said that equity is often used as to signal a concern about systematically disadvantaged, disproportionately burdened groups in our society. And in fact, when the Advisory Committee on Immunization Practices departed from the National Academy's recommendation in December, it departed on this point. It prioritized essential workers, essential workforce categories that employ disproportionate numbers of low-income people and people of color who are in low-wage jobs and who are at elevated risk of contracting the virus as a consequence, and said as a matter of equity, we need to bump up the prioritization for essential workers. And it's a very compelling argument when it's made this way. The problem is that it's a simple sort of policy prescription for a much more complicated, socially heartbreaking problem. And the point I want to make here is that without intensive investment of resources to increase support for and access to vaccines among people of color and among low-income people, it doesn't matter which group you prioritize, your equity objectives won't be met. So we've had a kind of natural experiment to provide evidence for the point I've just made. Could I have the next slide, please? And that's with respect to health workers. So as I've said, and we all know, health workers were prioritized. I don't know what the experience has been in Chicago generally or at the University of Chicago in particular, but I will tell you that as this slide illustrates, there has not been equal uptake of vaccines among all health workers who have been offered the opportunity to take vaccine. In fact, it's been quite the opposite. Low-income workers in the health workforce who are disproportionately people of color or and also people for whom English is not a primary language have been way less likely, way slower to come forward and accept vaccine than other workers in the health workforce community. So this is a hard to make out slide. The data are a bit old. It closed out at, I think, January 14th or so, when at this point in these states, most of the people who were receiving vaccine were health workers. And to give you an example, just to pull it out, in the state of Florida, African Americans make up about 23% of the health workforce, but only 6% of African Americans were so vaccinated. To give you another example from the Mid-Atlantic where I am, in Maryland, Virginia, and the District of Columbia, in the early days of offering vaccine to nursing home staff and residents, nearly 80% of nursing home staff were reported to refuse vaccination in the first wave of offerings. And similar data came from North Carolina and from Connecticut. It's not hard to understand what's going on here. We should have a conversation, and I hope that we do, about the justified distrust that many people of color and many low-income people have towards public institutions in general in the United States and to public health policies in particular. But look, nursing home workers have never been treated well in this country. They've been treated very poorly. They've been disrespected. They have a very important job to do, and nobody gives them the respect and the compensation that they deserve. And so they were, not surprisingly, skeptical about being offered vaccine early. Now, how much of this is sort of the early waves of vaccine offerings is unclear. Things seem to be getting better, but it's at least plausible to think that the phenomenon that we observed and sadly experienced with health workers would also repeat itself in any other prioritized workforce unless we address what are the real causes or concerns. And let me just say that the same problem exists if the strategy is to prioritize by age. And let me give you some examples again from the Mid-Atlantic about what we've been experiencing here. When the District of Columbia first opened up vaccine registration to people who were 65 and older, and it did so early. So it was one of the states that went in the direction of let's prioritize by age within a day, right? The wealthy, mostly wealthy, mostly white residents of one ward of the city. So the city's divided in wards like a state might be divided into counties. Ward 3, which is the ward I live in, right, had booked nearly 20 times as many appointments for vaccine as the residents in Ward 7 and 8, which are the two poorest states in the district, two poorest wards in the District of Columbia, with the highest proportion of African American and Hispanic residents, and also a disproportionate burden of COVID-19 disease. The district has since taken steps, which I'm happy to talk about, to address this problem, but it's been reported all over the country. Next slide, please. I think this encapsulates the reality. George Jones is the head of a wonderful NGO in the city called Bread for the City, in the city of the District of Columbia, and his location is a vaccine clinic site. And Jones gave this quote to the Washington Post: "You have to be intentional about warding off these disparities, because if you just let sort of equality reign the day, you don't get equal results." Next slide, please. So I'm going to end with what I'm calling a 6-point plan for how to address the allocation of vaccines in a structurally unjust world in the context of the United States. I'm going to run through these very quickly, and then I'm happy to talk about them in discussion. We need to engage frontally with justified distrust. I've already referenced that, but I think it's pretty clear what we're talking about here. We have been talking about the problem of justified distrust in the African American community, in the Native American and Native Alaskan and Hawaiian communities, people of color, people of poverty, for a very long time, and we have not made the strides that we should, and we need to immediately engage frontally with justified distrust. We need to reduce barriers to vaccine registration. It is way too complicated for most people who are not affluent and privileged and who are not younger to deal with the registration systems in many states and cities. We need to prioritize location of vaccine distribution sites in structurally disadvantaged and disproportionately burdened communities. We need to allocate vaccine disproportionately to those vaccination sites. We need to restrict access at those sites to the residents who live in those neighborhoods. And finally, we need to set measurable equity objectives. We have to be able to collect the data, which is not now being collected in many, many places. We need to monitor the data, and we need to self-correct in real time when we are falling short of the objectives we set for ourselves. So next slide, please. So with that, I'll stop and look forward to whatever time we have left for questions. Thank you.
Thank you very much, Ruth. That was an incredibly expansive talk, and I'm sure the rest of us, I'm still trying to digest half of it. I want to start with a couple of questions about the excess, and what are the countries that are buying 4 times the amount that they need planning to do with it?
Well, or 6 times the amount, right? So
right.
Part of this is understandable and perhaps even defensible. So in prospect, no one knows which vaccines are in fact going to be determined to be sufficiently safe and effective. So you're hedging your bets and you're making deals, right? And when you make these deals, since you don't know, you're going to perhaps make deals with more to get more vaccine than you actually need in principle. So you might think about this from an investment point of view, right? On the other hand, you can introduce some criteria that would help you make some more sensible decisions here, including options that you can release and all things of that sort. There's a lot of conversation, and now a document that's come out from the WHO and from COVAX, essentially providing guidance to countries for what they could do with any vaccine they determine to have left over. But that's leaving open the question of when you decide that you have enough vaccine left over. And that's really the kernel of the challenge with respect to the vaccine stockpiles. But what happened when they did this, the countries have done this, if essentially, as the analogy goes, they went shopping before anybody else was even in the store. You see this right now between the UK and Europe, even among wealthy countries. So this uneven, unfair global bargaining situation just completely has devastated low and middle income countries and compromised COVAX's ability to secure a vaccine on behalf of low and middle income countries. We've got to stop this, and we can release some of these options. We can do a lot of things right now.
What about the whole issue about the difference in origin and in quality of the different vaccines, as well as storage requirements?
So we've been throwing I don't know. My mind is going to sports metaphors, but it's like you got an incredible hit to the head here, or blow to the belly, with respect to these variants and what is going on, for example, with the AstraZeneca vaccine, and how to understand the situation that we're in. So we're going to have equity issues globally at multiple levels, right? It does continue to look like the, quote, most effective vaccines are the ones that are the high-tech, the mRNA vaccines, and therefore the ones with the biggest cold storage requirements that make it hard for even rural places and high-income countries, but for many places in the world to use them. That said, Moderna and Pfizer are working fast, it's my understanding, to come up with formulations that will reduce, get Pfizer closer to Moderna closer to AstraZeneca. Everybody's trying to get an easier formulation going, but there's that. There's also, though, the worry that some of these vaccines will be either more effective or more easily adapted to variants as they come up that have different properties from the standpoint of the vaccine. So you could end up with a situation where vaccines that will not be approved for use in the U.S., or at least will not be approved in the U.S. for a while. I'm not making any predictions. So anybody here who's listening, I'm not making any predictions about what the FDA will do with AstraZeneca in the U.S. But the data set that the FDA will have is a different data set than the data set that the UK and EMA, the European Medicines Agency, and the WHO has seen. And that is going to complicate everything and send all kinds of confusing messages to the global public about the difference between these vaccines and their relative effectiveness. But we're going to be sitting there thinking now, if thinking about the obligations in global justice were complicated before, right, when we're just thinking about rate of transmission, say, and vaccine supply, and we have to make some assumptions about herd immunity and blah, 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 blah. Now it's like a multidimensional crazy problem because we're throwing in the different variants, the vaccines with the different properties. We don't even know what to do about herd immunity. That's not me, but the public health and science experts. And the focus is now going more and more to preventing severe disease and death. Should we just think that way? Is that all we should be thinking about? And maybe, AstraZeneca will turn out and other vaccines will turn out to be pretty comparable when it comes to preventing severe disease and death, even if they're less comparable with respect to infections. And who knows is the question. So it's emerging data, whatever bad metaphor, we are building this as we're flying it, and it's not necessarily going clearly.
Thank you. Along that same vein, there are a couple of other questions about the global, and then there are a lot of questions that I'll take us more nationally. But can you talk a little bit more? I mean, you did talk about the geopolitics, but
yeah,
talk a little bit more about that and just using this vaccine, particularly in Russia, China, India.
So the Russians and the Chinese have invested heavily, as I'm sure everybody here knows, in developing their own vaccines. Those vaccines have not been vetted yet by what are called stringent regulatory authorities. So the FDAs and EMAs of the world, although they have been vetted by some other countries' regulatory agencies that are less well resourced. India is a different story. The Chinese and the Russians have been very much promoting their vaccines in low and middle income countries, and especially in countries where they have strategic geopolitical interests. In parts of Africa, for example, it's my understanding, I haven't yet seen these, but I've been talking with colleagues. The Russians are running a kind of information campaign, undermining some of the vaccine candidates that are likely to be used in those countries, sort of favoring the Russian products. This is no different than the soft diplomacy kind of strategic games that are played by different global powers with other resources that low-income countries or investments that low and middle-income countries need. I am not the expert in international relations by any means, but I've been looking at this with colleagues. And the problem is we are way behind in this game, right? So insofar as our, again, self-interest in our geopolitical position in the world, right, matters, it does look like that's another motivation for wealthy Western countries, right, to be more forthcoming so that they don't cede the sort of bulk of the ground in especially self-paying middle-income countries and high low-income countries who are making these bilateral deals with Soviet. I say Soviet because their vaccine is called Sputniks. So I keep thinking Soviet era, but it's the Russian Federation's vaccine and the Chinese vaccine. Yeah. So there's that.
So going more to the U.S. with the one of the issues that keeps coming up in the chat is to talk a little bit about vaccinating incarcerated individuals who are an incredible source of bringing infection to the rest of us. Well, but also a very vulnerable population just because of their living situation.
Yeah. And in some states, quite a number of states, they're prioritized fairly high up. So there's an argument to be made that is a very compelling one, that for people who cannot themselves institute any of the NPIs, the non-pharmaceutical interventions that reduce risk of contracting the infection, there is a special obligation to provide vaccines. So incarcerated people for sure are at the very top of that list, as well as people who are living in highly dense communities and in highly dense living arrangements. Many people in small compass and small places in neighborhoods that are crowded and dense. And then you can think of other institutionalized settings. There are some people who want to extend that to university students. We can have an argument or a discussion about how to think about that. But certainly the analogy is made between residents of long-term care facilities, for example, and people living in prisons. The difference, of course, is because the age structure is different in long-term care facilities, the rate of death is so much higher than it is among incarcerated populations. Some states, and so this is this tension, these are groups that all have, right, strong moral claims on vaccine and high prioritization. Some states have just folded, and I think you're going to see this happen more and more. I looked at Illinois just before we came on just to see, we monitor, I'm part of a group that monitors what's happening on all of these, but look, the political response is just to put a whole bunch of groups in the same phase. It's like, okay, next phase is now open to everybody over 65, everybody with a comorbidity, all essential workers, and everybody who's incarcerated in the state of Illinois. The problem is the supply hasn't increased. So when you prioritize everybody, you prioritize nobody, right? And that's part of the challenge that we're facing right now.
Well, so you get into a real stress when you prioritize no one because of the voluntary nature.
Well, you end up with more equity considerations that are problematic. I mean, like you have to figure out, and there's a lot of micro sub prioritization that happens. So a health system gets I don't know, a gazillion doses of vaccine, never a gazillion. I don't, they get 10,000 doses of vaccine and they're told by the state, okay, here's who's eligible. Your patients over 65, your health workers, anybody who can say that they're a teacher, anyone who works for the transportation system, and anyone who is working in a grocery store, right? But you only have X number of slots. How are you going to give them out, right? And who's going to get to them first? This way of going about it isn't helping anybody. Now, the other way to go is say, like, forget all of this. The line you hear is just let's get lots of vaccine in lots of people's arms. There's got to be somewhere between these two right now, right? Where we can have some justified prioritization that is feasible and equitable to implement, not equitable in theory, right? But equitable in practice.
Which is very complicated when you have a public health measure that you want to give it to everybody, and yet you have a voluntary system and you have so much distrust in individual communities. So easy to say in theory, we need to educate, we need to motivate, we need to sort of look at people and say, you have a right to be distrustful, but this is still the right thing to do. How do we do it in practice?
So I'm not the expert here. Fortunately, I have colleagues, as we all do, who are. It seems like the basic principles of health communications one-on-one still hold here. And they are principle 1, principle 2, principle 3, credible communicators, credible sources. So everything seems to begin and end with having the right people advocate with the right communities. Some places that have done a phenomenal job, right, have been at this for months and months and months. There's a phenomenal person who works at HHS, who is himself Navajo, who has been working with tribal nations for months now, building the base for understanding and acceptance among tribal peoples. There's a wonderful group, a colleague of mine for many years, Reed Tuckson, who is one of a very large group of African-American physician leaders who have been working for months in District of Columbia in particular, but elsewhere. He used to be the commissioner of health in the District of Columbia many years ago, to build awareness of and trust in the community here in DC. And there's a town, I'm trying to track down the details of this, but there's a small town in Rhode Island that decided to take measures in its own hands. And they went first to their residents in public housing, which most jurisdictions have not done. And there are all kinds of legal and other sorts of issues that people suppose, but the mayor, the health commissioner, the public health physicians, the community clinic leaders basically said, we're going to take the vaccine where people who are most burdened by COVID-19 live, right? And I know that there's been a huge sort of empirical debate, forget the law for a moment, about whether if we go first to people of color, that will be perceived as fueling the concern that they are being singled out for essentially sort of mass experimentation. So we've got these two narratives that we are struggling with. On the one hand, a narrative of, wait a minute, if you're coming to us first, there must be a problem. And conversely, wait a minute, you're going to rich white people first. We're the people who are dying, right? So I'm not suggesting that it's easy. I'm suggesting that, in fact, we have to confront it and not think that we can solve equity issues by deciding which group to go to first. That's sort of fascially race neutral, right? That's not the way it's going to go. And to secure equity objectives.
Well, so you just raised one of the tensions. The other big tension is the utilitarian argument of let's focus on the elderly because they're the ones at highest risk of dying, and yet there's the equity issue, as you pointed out.
I think
school teachers and the essential workers.
So I'm all for right now a simple, and in fact had an op-ed with two colleagues out 2 days ago, where we argued right now at this moment what we need is a simple prioritization of people, I would say over 60. We said 65 in the article, but I would have said over 60, and I'll explain why in a minute, coupled with a way disproportionate effort to meet people who are of color and who are poor in those age groups, right? What ACIP did first, just because we need to get in anticipation of what's likely to be a very significant increase in burden of disease from the variants, we need to get the people who are most vulnerable to severe disease and death protected first. We must do that if we're going to protect. So I'm totally on with that argument for a lot, not just utilitarian, but for a broad swath of good moral reasons. I'm going to say this in short compass because we're well past time. But the ACIP, when it first made its modification and said, let's do essential workers for equity reasons, they got some pushback and they said, okay, let's do people over 75 and essential workers. It was very well intentioned, but it was exactly what you shouldn't do, because if you step back for a moment, who dies over the age of 75? You got to live first to be 75, right? To die over the age of 75. And for all the same structurally unjust reasons that you see more COVID disease and more death in people of color and poor people, they also, as a population group, have lower life expectancies. So basically what you were preventing by an over 75 cutoff is a disproportionate amount of death. And every death's a tragedy. I don't want anybody to die, right? So that's always the problem that we're in here. But setting it at 75 was completely the wrong thing to do. In fact, to capture sizable numbers of mortality, disproportionate mortality in people of color, you've got to go to at least 65, if not 60. And for Native American peoples, 55, right? Just because of all the things we all know, right? So there has to be equity sensitive thinking all the way through. It's still the case that more white lives will be saved by an over 65 strategy proportionally than more Black lives, if we want to think it that way. But we can really adjust for that to some extent by really trying to work hard to get our older African American and Hispanic and Native American people vaccinated first, right? Among the first of everybody.
So just, we thought about that here, and the decision was to bring it down from 75 to 65 very quickly. And we also did priority for those in certain zip codes who are our patients.
Then you're doing it exactly. Then I would say hats off to the University of Chicago. Yeah. That's exactly the kind of thinking.
But again, the issue of voluntary and the rates of refusals are
high,
incredibly high.
And that has to be coupled. So now in the district, which made exactly that move. First, it was by preferential, it's a combination now of each week, vaccine is offered first in the hardest hit wards and only to people who live in those wards, right? And all the vaccine is being used up in the week's allotment. Where we're going, so far, demand, even in the African American communities, is exceeding supply. It just is harder for people who are less well off to be able to navigate the systems to sign up, which is the other piece that really has to be addressed. If you're dealing with a population group that has hesitancy for very good reasons, right? And you put in a single barrier or obstacle, the combination, exactly, Lainey. It's forget it. We've lost the game before we've even, sort of been on the field. So all of this stuff has to happen simultaneously. I'm not saying it's perfect yet in the District of Columbia or even close to it, but it's something akin to the thinking that you're describing, combined with the efforts that are going on at the local level. And the hope is that in an odd way, this period of vaccine constraint will be to our advantage in the sense that as more people see their neighbors and their friends and their community leaders being vaccinated and everything is going well, and please let there not be some disaster, like some bad thing that happens in the vaccination program, then maybe by the time we have more supply, there'll be less hesitancy and less openness and people will want it more. But people have to come, it's where the vaccine has to be where the people are. It has to be easy for people to register. There has to be a lot of work beforehand. I mean, I don't know how much, and this is just as an aside, I don't know to what extent academic medical centers are talking to each other about the problems here. And we've got wonderful folks at Hopkins that are working hard on this issue, but just hearing what you've done at Chicago, I think it would be great if there was a lot of
So to the credit of Chicago, the academic medical centers all over Chicago are all in communication. So we are trying to do this at a city level.
We are in Baltimore as well, but I'm thinking beyond, like there's a lot of learning in real time that could be happening, right?
Absolutely. So Ruth, I would love to keep you on Zoom for another hour, but I'm being pushed that the time is way past up. And I want to say thank you so much for a fabulous, fascinating talk. If Mark wants to say a word, he should unmute himself on one, but not both, or we'll get bad feedback. Okay. Go ahead, Mark. Give it the last words, and I just want to say thank you on behalf of all of us.
Ruth,
Mark. We see two Mark Sieglers.
Ruth.
Thank you so much.
Bye.
Stay well.